I wanted to go back. We talked about guidelines earlier and how it's difficult to keep them up to date, and often they aren't. I'm wondering, in these choices of therapies and treatment decisions customized to patients, if you look at the ADA or the ACE guidelines, are they helpful? Bob mentioned earlier decision support. You know, are they able to keep up with the advances in the availability of pharmaceutical therapies?
So I think that this is the real strength of professional societies, in being able to look at all the available data as clinicians and educators who are tremendously knowledgeable about the field, and then make recommendations. And so I've had the honor of serving on the ACE Diabetes Guidelines Committee for a number of years. And we've worked very hard to try to say, what's the real evidence that's out there, and now how can we actually make recommendations of what you should use at what level of A1C, and what caveats should there be about individualizing. And ADA has done a wonderful job also, but you mentioned something in the introduction which I think is so important, that if one actually reads the text of the guidelines, the 30 pages or so, they're all tremendously nuanced and fascinating. If you only limit yourself to the one-page summary of summaries, it'll be extremely, apparently very specific, do this, do that.
Lots of people like the Cliff Notes or the one-pager.
Although with the newest guidelines, I think there actually has been a nice step forward in terms of the summary of summaries, as you put it, with ACE in particular, showing, you know, these agents have these strengths, strength of effect, and also risk of side effect, and kind of giving some ranking, whereas the previous guidelines have sort of been metformin and then anything else.
Mm-hmm. And I think that the point is to be thought-provoking, such that the clinician is at least thinking about moving the needle and pushing the diabetic towards goal, and not to be in a place of what we call medical inertia, where there's the resistance to push them to the other end or add a second or third agent.
So somebody mentioned earlier adherence, and in the patient perspective, we are at the American Journal of Managed Care Patient-Centered Diabetes Care Conference, and imagine that, thinking about the patient and involving the patient in treatment decisions. I'm wondering, you know, where do we think we are in practice with these decisions, and really engaging, you know, shared decision-making, as you mentioned, Bob, and understanding, explaining to patients the trade-offs. Very difficult for clinicians to understand this, let alone to be able to communicate this to patients, I would imagine.
This is very challenging. This is extremely challenging. You know, we are trained to put the cure, the treatment, the eradication of disease first. Many of us in medical school were trained that way. It is one thing that I think is becoming innovative in medical school now, at least at the University of Missouri, where, you know, I help teach a course where we bring together nurses, pharmacists, medical students. We all sit in one room and we talk and we work as a team through the medical care process. But the other thing is also, and that I think the medical homes do very well, is to look at the patients and what their priorities are. I mean, I see a fair number of my referrals, so to speak, are, you know, well, this patient won't go on insulin. You know, please get him on insulin, okay? And, you know, sometimes sitting down and talking with that patient, well, why aren't you doing insulin? What are your concerns? What are your priorities? You know, is your priority to, you know, get your A1C down? Or is your priority, you know, not to have these side effects, not to have hypoglycemia? Do you live alone? You know, do you have some cognitive challenges? And trying to build a treatment program for them, which is really what patient-centered care is all about.
Right, so it's so difficult to really get over this adherence challenge. I mean, you know, there are good studies of statins, let's say, which show that at best you see among people with diabetes maybe a 70% treatment adherence over the period of several years. Insulin, as a diabetologist, I happen to know that if you're supposed to take insulin in a certain way and you don't take all of those shots, you're not going to really click. This morning, somebody came to me, a lawyer, very intelligent, who I've been working with for years, and I finally convinced him to actually take a multiple daily insulin regimen. Came back and he said, you know, I'm taking so much less insulin, but I'm actually taking those shots, and my blood sugars are so much better. But how do we get people to adhere to these regimens when there are so many things that they would rather not do?
Well, you know, I think part of it is you're absolutely. I mean, it's a big challenge. I think providers are not trained well in how to do that, and there are some best practices around doing that. You know, and you gave some great examples of using open-ended questions, not being directive to a patient and say this is what you need to do, but here are some choices. It seems like you have concerns, and you know, I think we don't do a great job of asking about adherence in the right way, as opposed to saying, do you take your insulin, where most people are going to answer their doctor, yes.
Yes, they won't
you know,
please us.
right. If you ask, you know, many people find it challenging to take insulin all the time. How's it been going for you? They're much more likely to be honest, and now you can engage in a conversation about what are the barriers and you
Yeah,
know,
what are the barriers? That's
right,
one of my
what are the
favorite
barriers?
questions.
Yeah,
What's
right,
the barrier
right,
to
right. What are your
Right.
concerns? And then you can work with them to problem solve.
I happen to have noticed that your blood sugar today is 404 and your A1C was 13. Have you been having trouble taking your insulin?
Yeah, right, yeah.